Hello everybody, and a really warm welcome to our Ask the Expert session on homologous recombination deficiency and genetics. We are so pleased to see so many of you here today to join us. I am Lizzie Hussain. I'm Deputy Director of Services at Target Ovarian Cancer, and I'm thrilled to welcome Dr Alex Murray, Consultant Clinical Geneticist and Clinical Director at the University Hospital of Wales, to deliver the session for us. This is looking to be a really great session. First, we're going to hear from Alex, who will lead on a presentation that will offer some evidence-based information about what HRD is and what it could mean for your or your loved one's care. You'll then have the opportunity to put your questions to Alex during our Q&A. Anything that comes out of this session is not medical advice, so it isn't a substitute for the information and advice you've been given by your own clinical team. Unfortunately, we're not able to answer questions about very specific individual situations today. The idea of this session is that we give you an overview for any conversations that you'd like to have with your own healthcare team. If anything comes up today that you aren't sure about, like what it might mean for you or your loved one, or if you have any questions or concerns, then as I mentioned earlier, you can call our support line to get more information. So now I'm going to hand over to Dr. Alex Murray. So Alex, could I ask you to take over and introduce yourself, please?
Yes, thank you very much, and thank you everyone for inviting me to come and talk to you today about HRD and genetics. So as we've said, my name's Alex Murray, and I'm a clinical geneticist working in Wales at the All Wales Medical Genomics Service. So I deal with patients with a family history or a personal history of cancer that may be inherited. And hopefully today I can give you some sort of background about HRD. So I have a few slides which will hopefully answer some of the questions that people have asked, and then we'll go on and answer as many of the others that we can. So let's see if that works. I'm just going to really start with an overview of what I'm hoping to cover. So first of all, an explanation of what homologous recombination deficiency is. I'm going to use the term HRD going forward because it is a bit of a mouthful. I'm going to sort of try and explain why people will be tested and when during their pathway they'll be tested, what the test is, how it's done, and what the implications are. So what is HRD? This is a very good question. And I think before you answer what the deficiency is, we really need to ask ourselves, what is homologous recombination? So it is one way of repairing damaged DNA. So our DNA is our genetic material. It's sort of the fundamental building block of, everything our body does, how it grows, develops. And DNA gets damaged just through normal living, really. Lots of external factors can cause DNA damage. DNA can go wrong when it's replicating itself. And the body is incredibly clever and complex. It has multiple different pathways through which it can repair damaged DNA, partly depending on the type of damage. And one of those pathways is called homologous recombination. So a deficiency of homologous recombination is exactly as it says on the tin, really. It means when something's gone wrong with that pathway. And there are multiple causes of HRD, some of which are known and some of which are unknown. So hopefully this slide sort of gives a little bit of an overview of the causes that we know about that can cause HRD. And probably the one that most people are familiar with is BRCA1 and BRCA2 gene mutations. And I've used the word mutation because it's perhaps a little bit easier to understand than the sort of more scientifically correct terminology that we use these days, which is pathogenic variant. So sometimes you might hear that term, but I understand why we've changed, but it is a bit of a mouthful. So a BRCA1 or 2 mutation, which is a spelling mistake, an alteration within the DNA code of those genes that causes that gene not to function properly. And one of the consequences of that can be HRD. But that is only one of the several causes. And there can be other causes, both specific to genes involved in homologous recombination, but also there are things that we can't yet identify, that we know there are some tumours that show HRD, but we haven't identified a cause. And in fact, most of those causes we cannot actually test for the causes. And the one we can test for, and perhaps some of you in this room will have had personal or family members who've had experience of having testing for the BRCA1 and BRCA2 genes, that we can test for, but we can't test for many of the other causes. So if we limit ourselves to testing for the causes of HRD, we will miss a lot of people who have this particular feature in their tumour. And therefore, we're moving away from testing for the causes towards testing for the effect of HRD. And the effect of HRD is something we call genomic instability. And that is part of what we now do as part of the HRD test, which I will come on and explain as we go through. So the important point here is that testing for the causes of HRD will miss a significant number of patients who have HRD. And the reason that we want to identify people who have HRD is that those patients who have HRD in their tumour are more likely to respond to certain types of treatment. And of course, what we're all trying to do is improve the outcome for people with ovarian cancer, give them the most appropriate treatment that we can, that will cause the most benefit with the fewest adverse effects. And identifying HRD will hopefully enable us to prescribe newer types of treatment to more women. So I thought at this point I'd try and explain a little bit about how this works, and in particular about these DNA repair pathways that I was talking about. So in this diagram, if you look at the blue rectangles, first of all, these are normal cells. And if you think about the different repair pathways, and in this particular example, I've just talked about two different pathways, pathway A and pathway B. And in a normal cell, those two pathways work completely fine, and they both play a part in repairing damage to DNA. However, if you block pathway B for whatever reason, then that cell becomes reliant on pathway A, which is not a problem because pathway A is working, so it will just do the job and it'll cover for pathway B, and that's all fine, and the cell will carry on doing its thing. However, if you think about a cancer cell that is already got a problem with pathway A, that it's weakened for some reason, then that cell is dependent on pathway B. And if you block pathway B, that cell has no pathways that can repair damage to the DNA. That cell will die, which is exactly what we want to happen to cancer cells. So that is a desirable outcome. In the context of what we're talking about, we've got pathway A, which is the homologous recombination pathway, and pathway B, which is something different that we call base excision repair. And pathway B involves a protein called PARP. So if you have a problem with your homologous recombination pathway, you are like the cancer cell at the top right of this diagram, reliant on pathway B. So if we can block pathway B, those cancer cells will not survive. So we want to find something that will block pathway B, and that is a type of drug called a PARP inhibitor. It inhibits the protein called PARP, which is really important in pathway B. And I'm sure that some of you on this session today will have experience of drugs in the class that we call PARP inhibitors. PARP stands for poly-ADP ribose polymerase, which is why we don't call it that, and we call it PARP. PARP inhibitors, and there are several. In fact, I think there's more than the three I've listed here, but I think these are the three that are most commonly used in the UK. The first one to be approved for use in the UK was olaparib, and we have niraparib and rucaparib. And these are all different PARP inhibitors with some differences between them, but they all work in the same fundamental way, blocking that pathway, which is specifically more likely to work in people where they have a problem with homologous recombination. It's that combination of both pathways not working that is what we're looking for. So when do we do HRD testing? Primarily at the point of diagnosis. We test people who have, currently the indications are those with advanced high-grade epithelial ovarian cancer. So advanced is classified as being stage 3 or stage 4. And that will be particular types of ovarian cancer. So not every single person with every type of ovarian cancer would HRD testing be offered. In order to do this testing, we do obviously need consent from the patients, and therefore this concept of HRD testing might be raised by your gynecologist before you have surgery, or sometimes afterwards, once the tumour has been assessed by the pathologist. In order to get things done as quickly as possible, it's simpler to have the consent up front so that the pathologist knows before they even look at the tumour sample that they can send part of it off to be tested for HRD if necessary. Now, obviously, this is sort of straightforward for newly diagnosed patients. The pathway is quite clear-cut. For people who've been diagnosed previously, who want to know whether HRD testing is an option for them, that's probably something best discussed with your individual healthcare teams, but it is possible to do HRD testing retrospectively if it's deemed to be appropriate for that individual. So how is the test done? So the HRD test is done on a tumour sample. It's not done on a blood test, even though genetic testing often is done on a blood test. In this case, the HRD test is done on the tumour sample, and it is sent off to your local genomics laboratory by the pathologist in the hospital where you have your surgery, and they will send it to the company in America that offers the HRD test, which is a company called Myriad Genetics, who have been involved in cancer genetics for many, many years. And what we're looking for is both the causes of HRD and the effects of HRD. So they will look at the BRCA genes in the tumour, and they will either find that they are mutated or normal, what they call wild type. And they will also look for this appearance of genomic instability that I mentioned in that previous diagram, and they will give a numerical score to whether there is genomic instability. And the cutoff there is 42. If you have a score of greater than or equal to 42, you're considered to have genomic instability. If your score is less than 42, you're not. And you are deemed to be HRD positive, or at least your tumour is deemed to be HRD positive, if you have either a mutated BRCA gene in the tumour or genomic instability of over a score over 42, or sometimes both. And there will often be both, but one or the other is sufficient. If both those parts of the test are normal, then your tumour is not HRD. So how common is HRD? About 1 in 2 women with advanced ovarian cancer are HRD positive, which means that about 1 in 2 are not, 50%. And the reason why this test is so helpful is that if we were, as we did previously, just doing genetic testing for the BRCA genes, we would only pick up about 2 out of 10 women, whereas now we're going to pick up 5 out of 10, which means there's a whole, those women in a slightly sort of browny pink colour on this diagram would not have been picked up as having eligibility for PARP inhibitors in the past. So this new test is opening up the option of treatment to a much larger group of women than previously would have been available. And although this might be a slightly sort of backwards way of going through it, I thought it was important to sort of have a clearer understanding of what a positive test means. So if you have a positive for HRD, that means you are more likely to respond to this type of drug called PARP inhibitors. I think it's important just to say that it's not a guarantee of response. It's not a guarantee that it'll work in everybody, but it means that people whose tumours have positive HRD are more likely to respond and therefore should be offered the treatment, as opposed to people who are not positive, who have a much lower chance of responding and therefore perhaps a higher chance of having adverse effects from the treatment that isn't going to work. And because we know that having a BRCA gene mutation is one of the possible causes of HRD, if we have a positive HRD test, then you may also need to have a germline test for BRCA1 and 2. And a germline test is where we test the DNA you were born with, which is not the DNA that's in your tumour, the DNA that you inherited from your parents. And we do that with a blood test. And we can check whether or not you have got HRD because you have an inherited predisposition to cancer, or if it's just something that arose in the cancer itself. if you have an inherited predisposition, if there is a germline alteration in BRCA1 or 2, then we need to focus on management and surveillance for other cancers, and the BRCA genes are associated with breast cancer as well as ovarian cancer. And there are also the issues or the implications of testing for relatives who might also be at risk. So obviously, while on the one hand having HRD positive result opens up a treatment avenue, which for some women is very positive and a good outcome, it also means that in some of those cases there will be implications for family members. So it is going to be some additional things for some people to have to think about. I thought it might just be helpful to sort of kind of give a bit of a timeline of how things have evolved and where we've got to with HRD testing. Because I'm fairly long in the tooth, I've been around in genetic testing for quite a long time, and we didn't even start testing people for BRCA genes until the early 2000s. And at that point, we only tested people where there was quite a significant family history, personal or family history, but we didn't test anyone who was just an isolated case. And then some sort of 10 odd years later, we started introducing BRCA gene testing based on a woman's pathology of her cancer, regardless of family history. And we started off selecting those women quite carefully, perhaps people who were diagnosed at a younger age. Gradually that expanded and more women were offered BRCA gene testing, and that enabled people who had a BRCA gene alteration to be given a PARP inhibitor. But as I've said, that will have only identified a proportion of the women who might respond, which is why last year we introduced the HRD testing to enable us to offer that new treatment to as many women as possible. So those are the slides and the things that I wanted to say, but we wanted to leave lots of time for answering your questions.
So we're going to move into our question and answer session now. So we're going to start with some kind of basic questions we've been asked about HRD. Alex, so the first question we've received is, does HRD predispose you to other conditions?
So first of all, can I apologise for the lighting? I'm in a room with a light behind me, which doesn't always look like you can see my face, but hopefully that's a little bit better. HRD itself is not a condition. It is a feature found in tumours. But as I've said, some people with an HRD positive tumour have that because of an inherited predisposition, for example, an inherited mutation in the BRCA1 or BRCA2 gene, in which case that there could be an increased risk of other cancers, particularly breast cancer, and to a lesser extent pancreatic cancer, and in male relatives prostate cancer. Those are the main cancers associated with BRCA genes. So if your HRD is caused by an inherited gene alteration, then yes, you may have an increased risk of other cancers.
I think that leads us nicely into our next question, which I think you've partially answered, but it would be good just to check in. So somebody's asked, are you born with a genetic disposition for HRD, or does it develop as you age?
So as I say, though, that proportion of women, perhaps 20% of women with advanced ovarian cancer who have who have a BRCA mutation, they are born with that propensity to develop a cancer which may show HRD. But other people, the HRD is a consequence of the tumour evolving, and it's not something you were born with.
Great, thank you very much. So our next question is, does having HRD affect your prognosis?
That's a really good question. I suppose it's prognosis, of course, is a very difficult topic. I suppose what it does more than anything is it makes you more likely to respond to newer types of treatment. That doesn't mean that if you are not HRD positive, you won't have a good outcome from your treatment, because there are these days, fortunately, many more treatments available. But it does mean that you will have an additional tool in the toolbox to try and treat your cancer. But I think it's quite difficult to say it's as simple as improving prognosis.
Great. And that leads well into the next question. So someone said, if I have an HRD diagnosis, does this mean that my cancer is more likely to come back?
Absolutely not. And I suppose at this point I should caveat, I am not an oncologist, I'm a geneticist. So some of these questions may be better targeted to an oncologist, but no, it's not in itself something that it makes it more likely to recur. It's a feature that we can exploit in treatment, but it isn't in itself a marker for recurrence.
Great, thank you. And then we've got a question about lifestyle. So does lifestyle have any effect on HRD? And does kind of exercise, eating healthily, etc., can that have any effect?
Nope, completely unrelated. And as far as I'm aware, it is purely a feature of your tumour that's arisen during the development of that tumour, either because you're born with a predisposition or because it's just the way it's evolved. Nothing that you can do or didn't do can change that.
Great, thank you. So a question that's come in while we've been speaking. So somebody's asked, is HRD only present in high-grade epithelial ovarian cancer, or can it be present in other types? So the example given was low-grade serous ovarian cancer.
It's a really good question, and I'll be honest that I am not aware of it being found in other types of tumour. The reason I say that is because I think because PARP inhibitors have had a very positive impact, I'm pretty confident that if there was any evidence that it was present in a wider group of tumours, we would be pushing to have it used for those types of tumours. So my understanding is it's something that we tend to just see in those high grade tumours.
Lovely, thank you. And another one that's just come in during our chat. So somebody's asked, are there any clinical trials looking into more treatment options for those that are HRD positive? And if we are HRD positive, are there any ways that we can help with further research?
Well, I'm sure many of you who are patients in oncology teams will know that there's a lot of clinical trials out there looking at all sorts of different areas. I imagine that some of you have been part of those trials. Perhaps even some of you have been part of the trials that have led to our understanding of HRD itself. So there are always lots of clinical trials ongoing. I'm not familiar with all of them. But I do know that everyone is, once they've found one thing that works, they'll be on to the next thing, looking for the next treatment. I just don't know all of the details of all the trials, so that's definitely a question for an oncologist.
Thanks, Alex. And I think it's worth me mentioning right now that if you go onto the Target Ovarian Cancer website, we have a clinical trials database that just covers clinical trials related to ovarian cancer. So you can go on there, check out eligibility, like basic eligibility criteria, etc. And that can be used as a basis for a discussion with people's healthcare teams if they're interested in joining trials. So now we're going to move on to testing for HRD. So somebody's asked, HRD testing does not seem to be routinely offered at point of diagnosis. Why is this, and will this change?
So yeah, I think it's relatively new that it's been available, and I think it's adopted at a slightly varying pace between different regions of the UK. Some of those are operational reasons that don't always feel very comfortable. You're absolutely right, from where you're sitting at this, you think a new advance should be available immediately, and I know for a fact that every region is working really hard to have this available at the point of diagnosis for newly diagnosed patients. It's just that it can be adopted slightly slowly depending on the different people involved in the pathway. But I would like to say that there will be no part of the UK that doesn't offer HRD testing fairly soon.
Great, thank you.
I should caveat that. I know that it's available across England. I know that we offer it in Wales. I'm not as familiar with the setup in Scotland and Northern Ireland. I know the geneticist there will be working, closely to try and have it set up, but there may be some local variation.
Lovely, thank you. So our next question is, if someone's already on a PARP inhibitor, is there any benefit in finding out whether they are HRD if they don't already know?
That's a good question. I suppose if they are responding well to the PARP inhibitor, then there's a good chance they are HRD, because that would tend to be the reason for their good response. There may be, I suppose, some indication for doing the test if you aren't responding, particularly, I suppose, if it's causing you any adverse effects, and you wanted to have a discussion about whether there is enough benefit to keep taking it. And you know, we all know that people will put up with a lot to reap the benefits of treatment. So no one's going to stop taking a treatment without much thought, but potentially it could be a conversation to have with your oncology team about whether or not it's worth continuing. But it's not something on the whole that I think is generally being offered to people who have already been given a PARP inhibitor, mostly because I think that people who've been on PARP inhibitors for a while are already felt to have met the criteria for treatment. So I would imagine that's going to be a relatively small number of people.
Lovely, thank you. And we've had quite a few questions about whether that HRD testing can be done retrospectively. So if you weren't tested when you were kind of initially diagnosed, is that an option for people?
I would think it probably is. I believe that it is. I think there are some sort of technical factors that need to be sort of brought into consideration. So when you first have your surgery, your tumour is sent off to the pathology laboratory. Pathologist will look down the microscope, check that it meets the criteria for testing, will then take a little sample and send it to the genetics laboratory, who will send it off to Myriad. Once a period of time has elapsed, those tumour samples, and by samples I'm talking about the microscope slides that were looked at. I'm not talking about big blocks or sections of tumour. That those slides will still be available, but they will be a little older. And the quality of the DNA may not be as good as if it was sort of fresher. So there is a possibility that there may not be as good a success rate in doing the test. It's not a test we've been doing for very long. It's not a test that we have experience of in our labs. We're dependent on sending it to this company in America who do the test. And so we consequently don't know as much about the technical aspects of as we might if it was a test that we were doing in our own laboratories. But I think from our experience of doing other tests on tumours, we know that time elapsed from when the surgery happened can impact on the DNA quality. And therefore it's possible that there may not be as possible to do it for everybody.
Great. And we've also received a question about whether it's possible to access that privately. What are your thoughts on that?
I guess by privately, I'm assuming that we're talking about sort of using it as kind of like a top up. The difficulty of that is the operational process of getting the tumour to the testing company. So if a lady is having all her treatment through a private pathway with a private pathologist, private surgeon, private oncologist, and the tissue is within a private facility, there's nothing to stop that being sent off to the company in America, presumably on a private arrangement. The NHS setup is a sort of a funded pathway agreed between the NHS and the company, and so the samples have to be sent off in a certain way. My thoughts are that people who will benefit from the test should be offered the test, so there really shouldn't be a need to pay for it, would be my thought. But if people feel that they haven't been offered the test and want to know why, then that's a conversation to go back to your oncology team and say, why wasn't I? Could I be? Is it appropriate? If it's not appropriate, then it would be a waste of money to do the test. And if it is appropriate, then it should, in theory, be available.
Great. Thank you very much. So we've had a question about other genetic tests. So someone's asked, if you're both BRCA and HRD negative, are there any other genetic tests that might be useful for predicting effectiveness of other therapies?
That's a really good question. So, we've already said that 50% of women are of tumours are not HRD positive, and even when they fall into the category of advanced ovarian cancer, that that would be worth testing. So I think there are lots of different factors to take into consideration. I'm not aware of any treatments that are routinely available, but I do know that there will be other research ongoing to try and find other treatment targets, and it's a whole-time occupation for many hundreds of people, I'm sure, trying to find new treatment targets, but I'm not aware of any other genetic tests. People who have a family history should always have their family history assessed independently of their genetic test results. People are more than just the genetic test results. So people who have a family history, even if they've had a negative BRCA test, for example, they should still have a conversation with their healthcare team to say, does my family history warrant investigation in its own right, even allowing for the normal test result? If there's no family history at all, and it's just an individual who's had ovarian cancer, has had negative HRD testing, then I suspect there's very little further from a genetics perspective that is currently available.
Thank you. It leads us into another question. So someone's asked, do non-BRCA mutations raise the risk of other cancers?
I'm wondering if that's in the context of HRD or just in general. So if your HRD was caused by a mutation in a different gene, then potentially some of those may also have a risk of other cancers that are linked. So if they're in the same pathway, then they may have an increased risk of other cancers. For example, breast cancer would be prostate cancer potentially. Other mutations in other genes cause all sorts of different cancers. There are multiple, many different cancer susceptibility genes which have different combinations of cancer risks. But I'm guessing it was in the context of HRD. So the answer is yes, potentially, although probably less so.
Thank you. And we've also had a question about the kind of intricacies of BRCA mutations. So somebody's asked, are there subdivisions within BRCA mutations which might impact the efficacy of different drugs?
That's a really good question, and I'm not aware of any. I think potentially that may be because we're in relatively early in the, our understanding of HRD and how people respond to PARP inhibitors. So I'm not aware of any particular classes of BRCA mutation where people are more or less responsive to PARP inhibitors. That isn't to say that won't happen, because I think that's the general trend in our understanding of new areas is we have a general understanding, and then as time passes, we drill down and get a much tighter understanding. So watch this space, and that may evolve. And it may be that there's already early reports of those, but I'm not aware of them.
Thanks, Alex. So I think now's a good time to mention that we had quite a lot of questions sent in advance about PARP inhibitors and the efficacy of different treatments for ovarian cancer. As Alex mentioned, she is not an oncologist. So unfortunately, we don't feel that this is the right forum to answer questions on those, but as I mentioned earlier, our support line is available. We will be able to signpost you in the right direction to get answers to those questions, so please do give us a call if you'd like answers on that. And we are able to kind of touch on how mutations and HRD affect your eligibility, but we won't be able to give information and support around specific drugs today. With that said, we're going to move on to some questions specifically around BRCA. So the first question does actually relate to PARP inhibitors, and somebody's asked, when BRCA patients fail on PARP inhibitors, so I assume that means when PARP inhibitors are not successfully, are not working well, why is that, and is it possible to challenge that?
It's a really good question. I mean, I think it's important that we do emphasize that PARP inhibitors are an amazing advance, and they have done, change the course of treatment for a lot of patients, but they don't work for everyone, and it's another source of huge frustration, particularly if it's been built up as this great new treatment and you've got HRD in your tumour and we're going to give you this drug and it's going to improve your outcomes, and then that doesn't happen. That's devastating and frustrating, and the immediate question is, but why not? I've got all the markers that should make it happen. I think that's partly because there's so much we yet don't understand. Our knowledge, our understanding of genetics, of molecular pathology is advancing all the time, and we know more than we certainly did 5, 10, 15 years ago, but we don't know everything, and there are probably other genetic factors and environmental factors that perhaps contribute to people's varying response to PARP inhibitors. We do know that the majority of people with HRD will respond, but how they respond, how greatly they respond will vary, and there will be a small number of people who don't. And we don't really yet know why, but I'm sure that will be a source of real interest and research, because if there's a particular feature that people have that's preventing them from responding, we'll want to be able to identify those people so that we can focus on a different treatment that will work for them.
Thank you. So we've got another question here about BRCA. So somebody said, I've just found out that I have the faulty BRCA1 mutation. I'm 38, and what course of action would you recommend? Now, it's not entirely clear whether this is someone who has a diagnosis of ovarian cancer or someone who's worried from the perspective of a family member, but could you share your insight on that, Alex?
Yeah, so when someone's first found to have a BRCA gene alteration, whether they are, I suppose, if the person is found through having a cancer and having that tested and they're diagnosed, then first and foremost, the most important thing is focusing on treating that cancer. And that has to take precedence over everything else, because you've got to look after yourself and have all the correct treatment for that cancer. Then you have to think about, are there other cancer risks? And we had a question earlier about what other cancers might be linked. And the two main cancers associated with the BRCA gene are breast cancer and ovarian cancer. So if someone's having treatment for one of those, then there's the consideration about the other. And there are multiple different sort of options for managing that risk. And the best people to sort of talk that through with would be the genetics team, who can talk about surveillance, who can talk about preventative medication, risk-reducing surgery, all of which are options, but all of which need to be taken into consideration with different considerations about where people are at in their life stage and lots of other considerations. If the person has not had cancer and is trying to be proactive at preventing cancer, then again, the clinical genetics team are probably in the best place to talk through all of the options and help you get your head around the many different things that you now have to think about. Because whether you're a person with cancer or someone who's been tested because of an alteration found in their family, there's a lot of information coming your way. You're being bombarded and you've got lots of decisions that you feel you have to make. To be honest, most of the time you don't have to make them as quickly as perhaps it first feels. You have time to think it through and talk it through, and that's where the genetics team can help you.
Thanks, Alex. So we've got another question, and again, it's not entirely clear whether this is from somebody with a cancer diagnosis or not. But the question is, I have the BRCA1 gene. The only person who I've unfortunately passed this on to is my 25-year-old son. What I'd like to know is what's available for him and what happens if he passes the gene to his future children. So
I think all parents, their biggest concern, after obviously thinking about themselves, usually before thinking about themselves, if I'm honest, is their children and what that means for their children. And it's a really hard thing to think about, having passed it on, passed on a predisposition to cancer to our children. The important thing is that by helping them find out that they've got this, it means that you're putting them in the best position you possibly can to take whatever measures they can to minimize that. So for men, the cancer risks with the BRCA1 gene are not anywhere near as high as they are for women. It's from his perspective, that's relatively speaking good news. He needs to be vigilant, and the main cancers to think about are breast cancer and prostate cancer, but as I say, a relatively low frequency. For breast cancer, we don't subject men to mammograms, but we do recommend that they are careful and they examine their chest wall for any lumps or bumps. And probably from somewhere in their 40s, it's not unreasonable to have a regular checkup with the GP for measuring a hormone from the prostate called PSA. And that would tend to rise in someone with prostate cancer, and watching how that progresses, and if that's starting to rise, a referral to a urologist would be a very good option. In terms of the possibility of passing it on to future children, well, there would be a 50-50 chance of passing it on. And I would think it would be fair to say that the vast majority of people in that situation do not change their reproductive plans based on having a BRCA gene alteration. They accept that there's a chance, and that science and medicine evolves, and that by the time their children are old enough to be at risk, there will be new things available. But a small percentage of people do want to be more proactive and prevent the gene from being passed on. And there is an option of what we call pre-implantation genetic diagnosis, where people can have IVF and testing of embryos before implantation. But as I say, that is a very small minority of people. And the important thing is, if you know that you're at risk and you know your children are at risk, you can prepare them and they can be tested when they get to an age where that's appropriate.
That leads us very nicely into another question that we've received. So somebody said, a few years ago, I went to a seminar in London where they were looking at IVF for carriers of the BRCA gene and removing the faulty gene. Is that happening, and how do we show interest? So I guess the question there is that available in kind of mainstream NHS care?
Yes, so PGD, as we call it, which is where you go to a specialist unit, and there aren't a lot of them, but there is one at Guy's in London and a couple of other places, and you have embryos created, and then you test those embryos before they're implanted, and only implant what we might call unaffected embryos that haven't inherited the BRCA gene alteration, then with the hope that then that will then result in a pregnancy with a child who does not have the BRCA gene mutation that is available. The best point to access that is to talk to your clinical genetics department, who can talk you through the process of referral and what is required for that. That will vary slightly depending on where you are in the UK. There are some criteria for who is able to have that treatment, and they are based partly on age, other eligibility. People don't do well if they have a very high BMI. If people have children who are already known not to have the BRCA gene mutation, then they wouldn't normally be funded to have that process. But obviously, because we're dealing with a condition that comes on in adulthood, we wouldn't usually know if a couple already have one child, wouldn't know if that child was affected or not. So that wouldn't normally prevent them from having the treatment. If it was a childhood onset condition, funding is usually only available for couples to have their first child. The rules may not seem fair, but they are what they are. So it's good to speak to your local genetics team about what the local setup is and the pathway for referral.
Thanks, Alex. And we've spoken a lot about BRCA and it kind of going down through the family. And we've got a question here, which I think is your bread and butter, but I'm interested to hear what you say. So somebody's asked, what is the criteria for family genetic testing?
So we follow the criteria set out by NICE, more or less, and they say that we should test people with a 10% or greater chance of having a BRCA gene mutation, and that is whether they've got cancer or not. And you can work that out on a couple of different methods. There's an online tool that a lot of genetic centres use called CanRisk, which you plug in family history information and lots of other information, which can then predict the chance of you having a BRCA mutation. It's not something we necessarily recommend that you do for yourselves. It's something your genetics team will do for you, taking into consideration all the cancers in your family, the types of cancer, the pathology, the ages, etc. There are also certain categories of patients who are eligible automatically for BRCA gene testing. I should say breast cancer gene testing or ovarian cancer gene testing. There's a test directory of all the different tests that should be made available for genetics, and different criteria are listed for different situations. So, for example, all men with breast cancer can be offered a breast cancer gene test. All women with high-grade epithelial ovarian cancer, regardless of age or family history, can be offered a test. So there's certain categories where you would get a test regardless of your family history, and in other cases it's based on the extent of your family history, how closely your affected relatives are related to you, what diagnoses they had, the ages of their diagnosis, etc.
And those criteria are specific to you if you have a known BRCA mutation, but not if you have HRD in your tumour, is that right?
So, if you've got HRD in your tumour, you will nearly always get a BRCA gene test as well, simply because we need to distinguish between HRD for inherited reasons and HRD for non-inherited reasons, so that we can look after the rest of the family. So depending on where you are, there are different ways things are done. In some places, every newly diagnosed high-grade epithelial ovarian cancer patient is offered a BRCA gene test, a blood test. It's done regardless of pathology, surgery, anything. They're offered that test. And if you have a BRCA gene mutation picked up on that, all of the usual advice about family members and screening then comes into play, and you will probably be offered a PARP inhibitor if that's deemed appropriate. You may not even need an HRD test, but because those two things will probably happen simultaneously, you'll probably end up with both. In some places, they may only do the BRCA gene test after the HRD test comes back, because you wouldn't expect to get a positive BRCA test if your HRD test was negative, because it includes testing of the BRCA genes in the tumour. And if you are born with a BRCA gene mutation that you've inherited, it's in all of your cells. So not only will it be in your circulating blood cells, it will be in every other cell, including the cells that then become cancerous. So when we do BRCA testing in the cancer DNA, we will pick up DNA changes that you were born with, as well as ones that have just evolved as the cancer developed.
Thanks, Alex. So we've got a question about what to expect from a genetics service. So a really interesting question. What should those of us who are BRCA positive and have advanced ovarian cancer expect from our genetics service? And just to give a bit of context, so they've asked, as someone with no evidence of disease and on PARPs, should I be talking about a mastectomy?
That is a really, really good question. So obviously, as I said earlier, the first thing we do when we find out somebody has a BRCA gene, if they are diagnosed through having a cancer diagnosis, is treating the cancer. Absolutely number one priority is we've got to get that cut on top of that cancer. But it sounds like this individual has had a positive response to their treatment and they're currently well. So they're trying to work out whether or not they should be thinking about preventing a further cancer from developing. And that's a very personal choice. Mastectomies are a big surgery. We do them a lot now, so we're getting good at them, but it's still a big procedure. It's a big, physically, it's psychologically quite a big deal. Having your ovaries and your womb removed is not nothing, but it's also not very visible. Having your breasts removed, there's quite a sort of psychological impact on you and your self-perception. So it's not something that people should think of lightly. What I can tell you what I say to patients in Wales, and that is I liaise with the individual's oncologist and ask them whether they think that it's appropriate. We don't have a blanket yes or no. No one's prior cancer diagnosis should preclude them from exploring their options. If the person is well and is not receiving any current treatment that would interfere with their recovery from surgery, and if the surgery wouldn't in any way jeopardize their well-being from their cancer status, then it's certainly worth considering. If that's something that a person feels is right for them. But it isn't right for everyone, and there is still screening. So depending on age, breast screening would be the other option, and that may be enough for some people, but it's certainly worth exploring, and that would be something absolutely that you can discuss both with your oncologist and with your genetics service.
Thanks very much, Alex. Moving on, we've been asked how many hereditary gene faults have been discovered and linked to ovarian cancer, and do you expect to find more?
So I was trying to think about my early practice in genetics 100 years ago when I first started, and there weren't many was the answer to that. And I think we knew about the BRCA genes, although when I first started we weren't actually testing for them. We just knew they were there and that we would test for them one day. I think probably there must be up to 8 or 9, maybe more, genes, probably a couple more that I'm not thinking about, that predispose to ovarian cancer, but some of those predispose to very rare and specific types of ovarian cancer. So not the same as the type, not these sort of high grade epithelial cancers that we're talking about here. I'd like to say that I hope we found most of the ones that are out there, but it's not impossible that something new could crop up. Although with the amount of research that's been done in the last few years, it seems unlikely that we will find any more what you might call high-risk genes. So a high-risk gene it's not really a scientific entity, but I use the term to mean genes that, like BRCA, which have a really high lifetime risk of cancer. So if you've got the gene, it's very likely that on its own is enough to cause you to develop a cancer. And there are a lot of genetic conditions, both cancer conditions and others, where having the gene is a direct causal relationship with getting the condition. But we know that genetic factors also are involved in many, many diseases, both cancers and non-cancers. I say to people, most of us have heard, we ourselves or a friend or a family member said, oh, everyone in my family has high blood pressure, or everyone in my family has diabetes. That's not folklore. That is because there are genetic factors that contribute to all of our so-called common diseases, but those aren't the same as the BRCA genes. Those genetic factors, they're not directly causal. They perhaps, each one of those little factors might increase a person's risk by 0.5% or 0.25%. Individually, they mean nothing. You can't measure them. You can't change your behavior because your risk is 1% higher than your next door neighbors. That's not practical. But if you accumulate 5, 10, 15, 20, 200 of these little factors, all of which have a minute increase in risk, then your risk is actually quite a lot higher than somebody else's. We aren't currently at a point where we can measure those, test for them, and quantify a person's genetic risk due to those which you could call weaker genetic factors or low risk genes. But I think we're getting towards that point where those kinds of tests with the advances in technology that we have, with the reduction in cost of genetic testing and the investment in research, I think we're getting to a point where those kinds of approaches will be possible. And some of you may have heard the term polygenic risk, and if you haven't now, write it down. You might hear it in the next few years, because it's a bit of a buzzword in the genetics community about whether or not measuring those individual weaker factors could actually help us stratify people in the population into those who really have no high risk, none of these adverse factors, even those little effects, you haven't got any of them, and your chance of getting that cancer is practically zero. And then there'll be some people who have perhaps enough that put you into a kind of intermediate risk, where actually you have a significant enough risk that maybe taking some kind of medication or doing some other kind of preventative measures might be appropriate. And that's completely outside of the BRCA genes or the other high-risk genes. So I think it's something for the future, but I would be surprised if we find any more high-risk genes. Famous last words.
Thank you, Alex. So we need to wrap up now, I'm afraid. But before we go, I just invite you to share the one thing that you'd like everybody to take away from today's question and answer session.
I suppose what I'd like people to take away is that you know, cancer's a really scary diagnosis, and you know, you often hear a lot of negativity, but of all the cancers that I work with, I think ovarian cancer is one where, you know, the trajectory of you know, is going in a positive direction. There's so much advance in the treatment options available, and while I totally understand that it's not the case for everyone, more and more women are being successfully treated, you know, having much better outcomes. You know, we're hearing stories about women who have finished their treatment and are doing really well, more and more than we ever used to. And to me, for a cancer that has traditionally been really, really hard to treat, it's great to hear those positive stories. And I hope more of you will be having those personal experiences.
Thank you so much, Alex. We're going to end the question and answer session now. I'm so sorry if we weren't able to answer your specific question today, but if you have any questions or concerns, or would just like to have a chat, our support line is available, so you can call us on 020 793 5475. It's on the screen. I'd also really like to take this opportunity to tell you about our information guide, which we've just updated. So you can find out much more about HRD in our genetic testing and hereditary ovarian cancer guide. It kind of just goes through all of the basics. It's a free expert guide for anyone with ovarian cancer and their family. So we've just published it. It explains what testing involves, what it means if your tumour tests positive for HRD, and lots of other information. So everything that Alex has covered today, but you can read it at your leisure. So you can order or download the guide, and you can visit our website to do that. You can find it at targetovariancancer.org.uk/guides. So I'm sure you'll all join me in saying a massive thank you to Dr. Alex Murray for sharing her expertise with us today. Thank you so much, all of you, for joining us. We hope you found it really informative and helpful. So on behalf of the Target Ovarian Cancer team, thank you so much for your time, and we hope to see you again soon. Goodbye.